Morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 170. We have a complicated case to show you today, hopefully with the numerous teaching tips, both an angulated lesion and with calcification, and we'll try to even do it with the image guiding, possibly with some physiology also, but I'll let Dr. Kinney and Dr. Sharma take you through the plans. But in the meantime, I have an excellent announcement to make, probably one of the most spectacular events for Mount Sinai Hospital. This is a new global and the US ratings which has come in the US News and World Report. Samin, tell us first about the announcement and then let's see the plans for the case.
Yeah, fantastic. And of course, we thank our CCC Live cases viewers globally, and with the recent and welcome from Mount Sinai Cath Lab with our routine players, with Dr. Kini on my left side, and we have our two fellows, Raki Makija and Frank Kalaba. The technician, same, Asif and Francisco, and our nurses, Ashley and Will, and imaging, our person, Kiski. So with that note, a very tough case which we are going to show, and the whole question people ask, what is the limit for angulation for the rotational atherectomy if it is a very calcific lesion, knowing that many of these cases you can do with the IVL, but many times IVL in the angulated may not make a curve. But with that note, the great news of having climb to number 4, if we can start our slide, number 4 in the US World News is here. I want to share, getting to that has been the dream, and I always was very focused on how to get up to the ranking. As you see here, that just about 5-6 years ago, we were number 10, and we're stagnant at number 6 for last 4 years, and today, this week, or last week, I would say, we climbed to number 4. And this makes it basically number 4 with the overall score of 93.6, maximum being 100, which is the various hospitals ranking. They take in account your outcome, experience, key program and service, and the professional recognition. So those are the 3 components, and they are changing apparently their reporting structure a little further, and so we climbed to 4th. The first being still remain, Cleveland Clinic. Number 2 actually climbed first time, it has been a Mayo Clinic since the inception, but now Cedars-Sinai became number 2. And number 3 remain Mayo Clinic, and we are 4th, just distant 4th. And you can see here, only thing we need to improve to go up in the patient experience and the expert opinion. Otherwise, we are excellent in all the aspects. So this is a great news for us, and real pride of Mount Sinai. It makes it now we have climbed everyone in terms of Columbia, last time NYU, and so this is the number 1 program in New York. But at the same time, look at the competition. There are 4 hospitals in first 10 of your World News from the New York City. Columbia, NYU, Lenox Hill, and ourselves. 4 of the 10 are from New York City. But tough competition, and making it to number 4 from there and top from that 4 is really remarkable. And it goes not only the cath lab, of course, the revascularization is a very big, because people are referred, expert opinion is for that, and services you provide in terms of complications and various part of those reportings, all the societies, and so those help, and we are very transparent in those issues.
Congratulations, and most importantly, I felt that because of the professionals recognizing it, I think that is a fantastic point.
Beautiful. Now, while we are getting this case, let's go through our usual presentation, same disclosures. So this is the case number 170, 76-year-old female presented with mild angina and stress test done as a pre-op for shoulder surgery. Patient has a bad osteoarthritis of the knee and shoulder, had few surgeries, and SAQ score was 89, just mild symptoms, but strongly positive stress MPI with multivessel ischemia, has been a normal ejection fraction and good medical therapy, and cardiac cath revealed revealed two vessel disease, multiple calcific lesion over the RCA, and an angulated circumflex, which we are going to show with syntax score of 20 and EF of 50%. Patient did have, look at this one. This was the done about a few weeks ago. Multiple calcific lesions in the proximal, mid, and distal RCA. Very calcified, you see that. And Anu did the rota burr with a 7 runs with 1.75 burr, ablation time of 130, post dilated, and then put 3 Promus drug-eluting stents. Made the artery fantastic. So this is where we are, and now we are going to show what we are today.
Samin, for the RCA, had you considered rotatripsy?
What did you know? It was in this case just I think after the I would probably would have done it. Yeah, I would have done. But I think it's a combination of two, and lot of it's nothing wrong in that. That if you want to do a rota and you do a high pressure balloon and it opens up is fine. Otherwise you change to the IVL, and that is what we have been doing now. Basically the rotatripsy, as you mentioned. To me, that allows you to use a smaller burr. In this case, like 1.75 ideally is too small. Could have been 2O plus, but then you combine with the basically the combine. You guys come in. Yeah, combine basically with the combination of IVL, and I think and we are evaluating our data that has rotational atherectomy strategy, burr size, post dilatation, and so, and more importantly, complication have changed pre IVL era at Mount Sinai and post IVL. So we are going to look into those data, and I assigned one of the fellow to look into from our massive interventional database, and we'll have our patients about 300-400 before and 300-400 after the IVL, and so we'll see the outcome, how they are in this current era. That whether my feeling is that IVL is synergistic to rotational atherectomy. It improves. It really allows us to use smaller burr, and in turn will lead to a lower complication. But that's anecdotal till we have the solid data. Okay, now we show the angiogram, Anu. We go to the fluoro, please. Yeah.
So EF near normal, that's where we are. Now we are going to 45% with the EF. This is the right coronary artery.
We always take a picture, and that's a common teaching to all the fellows when patients come back for stage intervention. Take a picture of your previous, because many times you'll see a little thrombus, little dissections, and so you can patch it up. Yeah.
And then we have the epicaudal. But I think the best to see the tortuosity of the circumflex is definitely LAO. So left main is non-obstructive, and then you have LAD, which is again non-obstructive, a lot of calcium. But look at the significant disease of the prox circ.
Anu,
Calcium as angle.
all the incredible lesions I have seen you do with rotablator, I have never even seen you attempt this angulation.
You really have to see angulation. There is an archived case that we did to India Live.
India Live, yeah. This one, that one was, yeah.
Yeah.
Right.
And what will happen, and we predicted in that case also, that even with your small rota bar, first will be, let's see how wiring and our exchange length catheter will be. Use a rota floppy wire and use a small bar, maybe 1.25. What it will do, it will going to create a gutter. It will make a parallel lumen, which is okay. But that means you have cut the interelastic membrane so that now you can dilate with a balloon and subsequently stent. You see that there is a tremendous calcification at that level, and you are going to go strategy and which balloon wire.
So we will do fielder fine cross and then change to, I think we just have to do rota floppy, not a stiff wire here. It will be a lot of wire bias otherwise. And then 1-2 bar.
Yeah.
Open the 1-2 bar. You know what? Don't open yet.
Two questions have come here regarding other alternative techniques using either a cutting balloon or orbital.
Yeah, so I would say that this is a type of case where there is a angulation. Orbital will give you more wire bias and more dissection because of the wire is 0.012 compared to 0.009. That's one. Second, whether the cutting balloon will make a turn is one of the issue. But point is, if you make a cutting balloon goes and it does not open it, then basically IVL will not make the turn, and you are in the much tougher situation than you plan the rotational atherectomy rather than a bailout RA. See that whole circumflex is outlined on a dry fluoro run.
Dr. Harris has asked a question which I am not following exactly. Question, hi, this is a patient for pre-op assessment with mild angina. Is there role of coronary angiogram? Is he talking about physiology here?
Yeah, no, basically, no, that is true
There's no
because
light
most
here.
of the trials,
happened?
particularly more of the vascular studies have shown the trial before the vascular intervention like AAA and
Okay.
abdominal surgeries and so that routine stress testing did not play any role. And even if you have ischemia, that advanced the revascularization did not make any difference. That is, having said that, if somebody has done the stress test already and it is positive, you know that that patient is not going to get a surgery until that revascularization is done. Nobody, I'm telling you, and we feel this very commonly, patients with mild moderate ischemia and they need to go for gallbladder surgery or some, and you start seeing that the anesthetist actually cancel the case because they say you have to take care of the ischemia. Now, you can, this kind of case with a near normal LV function, with a mild angina, you could clear this patient for a surgical shoulder surgery. But if you have done it, the anesthetist will not clear it, will not allow the surgery. That's where the trouble is. Mr. Parwar. Now you can see here trouble with the.
What wire are you using, Anu?
This is a fielder.
It's a regular fielder.
Okay.
Yeah. You can use the 120 also extend length and 120 or extend length fielder with course
Supercross.
Supercross 120.
Probably
No, I don't know,
more shape
Yeah.
on the wire.
Yeah, more shape, and the other one could try whisper and
wire, yeah.
and whisper wire and make a bigger curve and get ready.
You
can
get
ready.
run through ready also.
Huh? Run through is ready. Yeah, but you want a whisper or no? So just coming back to the point which somebody said, use the cutting balloon. You know that once your wiring is so difficult, it's not going to make any.
What is
the
this
whisper. That
Absolutely right.
nothing will go there. So key is all these things you plan ahead based on your experience. And one other thing which I wanted to say, people may say, well, I will try to see a balloon. Look at the calcium in that lesion. If I would say that straight segment, IVL would have been a fantastic. Lower complication, we know the very low perforation, but in this kind of case will be a delivery issue with IVL. I know they're making a lot of new modification. The latest IVL pulse C2 has started, which gives you 120 pulse. There's mild modification on the balloon, but not much. But I think those continue to improve, that we end up, we need will need a little more flexible catheter of the IVL. So I think that will be one of the part of the engineering design which is happening. Now we are using the whisper wire, but otherwise we are ready with the 120 supercross with the exchange length fielder. So this is the kind of case you need little angulated. Some people say, well, we can use a twin pass going into the ramus and with a side branch going to the circumflex. That is another view, but we usually never had a good success on that. So this is the kind of case where angulated catheter, whether supercross or venture,
Some dye here.
can be used.
You think an Amplatz guide would be
Oh,
No,
here?
no.
No, not the guide. I think guide, because we have so many adjunct issues nowadays that your supercross will be less traumatic, and guide, of course, Amplatz guide may increase your success a little bit, but definitely has a more trouble on the, the means chances of little dissections
Open
and
the
so.
Supercross.
Yeah. Ready with the supercross and exchange length? Yeah. Yeah, good.
I
What happened here? Lil die?
No, even the fielder made that.
Lil die?
but
Yeah, see?
then
Yeah, this is a whisper.
Viewers can appreciate when I called it an exceedingly complex angulated lesion. I
And
think
key is that, Anu really wanted to do this case for the CC because we had done tremendous bifurcation, rotablation, both vessels, and so that has been a lot of teaching points, a lot of our archives. But this kind of case is very rare, and this is for our CCC Live is one of the most angulated case. We have done one to the our India Live. Okay, so now our strategy has changed very quickly, which we expected. That we are going with a Supercross 120 with a exchange length fielder wire.
I don't think we should go exchange length. Give me a regular fielder.
No, that's okay. Right now you have it.
That's very difficult to manipulate. Pull the wire back.
So we want to show that 120 angle, yeah.
Bring this closer.
Your guide is there or came out?
What is this black line?
Excellent.
Get me a fielder 180.
Demonstration of your hand movement,
see.
Anu. Danny, great job.
Now, what is a vertical catheter?
Yes.
Right?
I
There is
don't
a
know,
wire or
It's some dark line on her. 180. Forget rota here, I think.
see the fluoro? Did we change it?
I think
leave
it's her chest.
May have some heart failure now.
Huh?
No, I mean, sometime some fluid in.
No. It's nothing to do with the fluid.
Find out what this is. Leave it.
EDP was okay, 15, so. So we're changing there. Let's see. It's not.
Good. Too far. No, wire. You have to put your wire.
Yeah,
first.
wait, not to worry.
Samin, another follow-up question from
we'll not go
Dr.
here.
Paris.
Yep.
The left main and proximal LED is good. Is there indication for revascularization, especially in pre-op assessment? With normal LVEF, most likely patient can safely undergo the op and only subsequently require recanalization.
Yeah. No, I would say that fully agree, and not only that, all these surgeries, whatever we do a pre-op stenting, although guideline we say we can stop the antiplatelet therapy after 1 month. Anesthesia, since it is only for high bleeding risk and it's not in the guideline, nobody pays. They don't want to do it. So it clearly, as I said, this patient, the things we are being done in this particular case to make patient clear for shoulder surgery, and knowing that it was clearly both inferior and lateral to ischemia. So therefore, we're targeting both of them, and that's all the reason basically is. But yeah, it means otherwise even complex cases, and I'm going to talk about that part in our updated guideline of chronic coronary disease, that these kind of cases, okay to have a medical therapy and normal ejection fraction for one vessel disease. Patient having not much symptoms, maybe does not need even anything. I would say that this kind of patient, if not an issue with the surgery and you have such a difficult anatomy, rather than causing any complication, it's okay to manage medically and not even do the intervention.
It's almost a double angulation there.
Yeah. Yep.
It makes the first angle and then it goes into some tiny branch there, and the plaque is
atrial branch,
right.
Some die now. Oh.
You're making progress. I think just a matter of persisting. There you go.
Or the whisper.
When it's made the first pass.
Let me come here now. And take a picture?
Yeah, I want to take a picture and then decide what is happening there.
No, it is in some branch.
Yeah, some small branch.
Yeah, it's in the branch.
I'm thinking, do I go miracle? Give me miracle 3.
You have to see some other view that are we in the branch or the main vessel. That's the key. So I think this is the whole case. If you're in the branch and you're going to with the wire, will be more trouble.
Okay.
Want to go magnify?
Just think
No, no, no.
another-
Yes. Okay. Magnify.
Another view will help here.
Ready?
Yep.
This should show it.
No, it's in the branch, all the way in the branch.
No,
See
but
that?
if I pull back. Okay. Now die.
Yeah, let's take a picture now. In this view, yeah.
No. So what happens is, branch comes easy. So if I take miracle, I may be able to get this down.
Okay.
You did not try the whisper though.
With not with this 120. We did a whisper earlier.
Earlier.
We had that whisper wire, yeah.
So it's
This
only
way.
going to
Throw
those
this away.
The
Yeah.
atrial branch, yeah.
both
This
atrial
is
branches.
whisper? No, throw this away.
Samin, as
What
you
is this
pull
one?
up the
Whisper.
next wire,
Yeah.
how much, first of all,
That's a
this
miracle.
is only as I continue speaking today, the achievement of the number 4 in the country is truly a landmark event, I think, for the hospital as well as for the cath lab.
Yes.
You think there has also been a significant contribution came also from the work in structural heart?
I think that is one of the big thing, in my opinion, what has been
absolutely.
structural heart and transplant, and also,
Peripheral.
basically, so all those things combined.
Right.
Because various, these are the big, and I would say one of the reasons for Cedars Sinai to go to number 2 is because of the transplant, because they do the highest number of transplant at this time in America, and the structural work. So they are both on top, both on the structural and the transplant. Not even coming out with this. You need a whisper, the new whisper, right? You have the whisper, 1 second. Get a new whisper, yeah. Yeah.
Some die. Let me see.
And of
This is
course,
straight
several people have been referring and suggesting angulated microcatheters.
No, that is
That's
it.
what it is.
Yeah.
Super
No,
cross.
no,
It
that's
is
what
super,
I'm
yeah.
saying. No,
Yeah,
which is what
yeah.
I'm saying.
Yeah,
That
yeah.
has.
Get me the fighter.
Good. So let me just complete our presentation today. Go back to the slide while we are just changing the wire. So this is basically was the plan for stage complex PCI of angulated calcific proximal circ. Hopefully using rotational atherectomy once we need to cross. And this is by definition is appropriate because there is although no proximal LAD but double anti-ischemic therapy and patient has a positive stress test. So this is basically the appropriateness of the point is A. And could be very well debated, and I have no question on that point. This kind of a complex lesion where there is high chance of complication, it's okay to manage them medically, but here issue is that patient the anesthetist will not do the surgery because of the ischemia. You don't do it, you clear it, it's fine, but once you, because ejection fraction is good. If EF is less than 30%, then they will definitely ask for some kind of assessment. But otherwise, we learned that there is really no need for any of those the testings, routine stress testings in these cases, because none of the trial has shown that. And same thing also the guideline. One of the guideline has come. We used to do a yearly stress test after PCI and so in a management of stable coronary artery disease. And the guideline actually has said it's a class 3 that not needed. Only if symptoms happen, then maybe you do some change of ECG or some, but otherwise routine stress testing for management of coronary artery disease, even after PCI, is not indicated. This is the fighter wire.
Not die now.
Nope.
That's
Same branch.
I think we have to go with the.
We also have
Get me the venture.
venture. Yeah. Let's see here where it is. Let's get a venture. No. Over the wire venture, right?
Yeah, over the wire venture.
Yeah. So that's another angulated catheter. So this is not helping out. Which wire you want in the venture?
Let me try. Okay, we'll try whisper with the
Yeah, I think we
venture.
need to go
And
to
then
whisper.
I need this. I
Yeah,
need this.
yeah,
This may
keep
do
it.
it, but
Yeah, give us a new whisper wire.
this
We have the
is
whisper
too
wire.
soft. You
Yeah.
see that? The super cross is too soft. Every time we are trying to advance,
Yeah.
we are losing the curve.
Good. So whisper is the same way. I mean, there's the venture that will make a curve. There are other catheters also.
Other techniques which have been referred here are Gaia, reverse wiring, pilot. So lots of people responding to a challenging case.
Yes.
Excellent. That is precisely the purpose of this interactive session. And as I had pointed out in the beginning, hopefully with many teaching tips today.
Yep.
Aye.
The backload.
Oh, this is backloading. Oh, that way.
Good. All right.
That calcified subtotal, you need a little stiffer.
Yep.
Let's see. This
So
will
right
not
now we are going with the venture plus our whisper. Keep going. We'll go into the ramus first.
Anu, would it help to put the wire in that atrial branch and then use the
No, I
second
tried
wire
that.
to-
Yeah. No, that
Very
means
early
parallel
part,
wire.
I did try.
No, but
with the
question is
Ramus.
parallel wire. No. There are two
that-
wires.
You cannot do that.
Yeah, two wire.
Yeah. Parallel wire. That one, no. Okay.
Yeah.
Okay, now let me turn here.
Good. Pull back a little back because tip, yeah, good. Now we are going to make the turn.
That is exactly in the right.
Yeah, good. This is it.
The best
Let's try.
moved a little bit. Here we go.
That's it. That's the rota floppy.
So you see why it was a different is definitely your venture stiffer and kept the curve. Let's
It
see
will be
which
difficult to
episode.
advance anything now.
Yes.
So
but
if you
let's
could
see.
hear the audience clapping, unbelievable. Immediately,
Yeah.
several of them have jumped on excellent, excellent. So, I
But
absolutely echo the
and I
sentiment.
wanted to emphasize once again, look at this. This is a venture, which is basically a 2-point, French catheter. The lumen will be 1.2 millimeter, not going because that calcium. So anybody thought initially that go do a cutting balloon and this, no. This is not say, well, it didn't go. No. It would not have gone. Not they did not go. They would not have gone. Even this one will be a little tricky, but we will be able to manipulate this now. Even if not, we can stabilize and bring out and put us some
Small balloon.
smaller balloon, yeah.
Right.
But now it is the bigger wire, and now same torque it with the wire in the left side.
First we undo it.
Yeah, undo
Remove all
it. So
the-
once you're across, you undo it now.
Undo,
Yeah.
remove
You want to just
everything.
take a picture first or no?
No, it's okay. Let me see. Guide is coming out. Okay, take us in. It's not.
Okay.
I was just thinking, are we there to do a rota exchange? No, no, we're
Not
there.
yet, not yet. No. It has to go.
Maybe a small balloon first.
Yeah. No, that is definitely could be a possibility.
Get
Get
me a
a-
2.5.
No. 1.5.
No. So we remove this.
No, will be very tough in this 6 French. I'm telling you with venture. You go with
I was
the
looking
dark.
at a 2.0,
Yeah, dark.
I was thinking.
Yeah, dark. Yeah, no, but that was for trapping it, for the trap. We had to exchange this, not exchange length wire. So give a dark wire. and then the Corsair might go.
People
There,
are
then you can
even
do some. Yeah.
speculating a laser, Dr. Nikhil
That
Jha.
is absolutely no. This is laser is a good possibility here. Absolutely. The only problem is any of these cases, if the angulated alone, laser will go. Once your calcium may not make a turn, but laser is a very good possibility in this case.
Want to recognize Dr. Srinjan Nandi and Nikhil Jha for keeping it highly intellectual and extremely
What
informative.
balloon do you want? I think Corsair first.
Give me
Ready?
a Godzilla first.
Yeah. Godzilla?
Yeah. Balloon will go. The thing also here, careful, careful. Because it's a 3-0 guide. The way okay, I have it. Then we go with the 2-0 balloon. No, I think 2-0 may make it.
Now tell me what is the purpose? We need to put our rota wire, right?
I think we'll do it without.
No. We have to do rota. That's the whole thing. Yeah. No, I know, but let's one by one. Right now, we need to put a catheter so we can exchange. Let's get a Corsair. What do you have?
Okay, then get the Godzilla. This one. We give the duck.
No, but Corsair will go. This you want to...
No, it's a. It may just keep going to so many side branches. Okay, connect.
But let's bring the laser machine to
No,
warm
it's
it.
coming.
No, I know.
Laser is here and we're getting warmed up.
Yeah. They are making a new laser because right now it takes about 15 minutes to warm up or how much?
5 minutes.
No. More than 5, huh? Huh?
No, 5 minutes. Yeah, maybe 7-8 minutes extra.
I thought 15, 20 minutes, no?
No, not
okay.
that long.
Okay. All right. Just 1 second. Rota floppy has been cleaned and ready, right? Beautiful. Good.
Hold the wire.
Yeah. So we are going with the Corsair now.
Let the wire.
Yeah, I know. Very back and forth. Keep going. So this is a kind of case also, even rota bar may not even make that turn even 1.25, but then you go to a little higher speed. Every year of the 600 rota cases we do, there are 2 or 3 unsuccessful. That means rota wire has gone, but bar does not go through. And many times you can change it to an extra support wire and so on and so forth. Let's repeat now. So it's separate now. Good. Remove that back. Good.
This is a regular Corsair, right?
Yeah.
No guide support.
That's
That's
it.
the issue.
You did? Good.
No. This is
No, it's went in now. 1 more millimeter, then you're good.
No, not there yet.
Mm-hmm.
Yeah.
Okay, there we go.
Okay, gotta be time for laser, I guess. No? Other thing is,
Can I just try 1 minute?
no.
Let me just try. You hear them? And let me just take care 1 second. Now basically course action is clockwise. After 12:14 you could do counter clock.
We might have reached there, no?
Let's see.
Lloyd has no support there.
No, no. Just few more millimeter. And this is the VL guide.
Okay, now went through.
Yeah, went through. See?
Patient is moving too much.
Low more sedation. Good. That's enough. Don't go further. Good. All right. Record it. 1 second.
Fluoro saves.
Yeah. Okay. Bring the rota wire. Floppy. Good. Fluoro. Is that coming out? Good. Just want to say, emphasize once again to all the people who said that let's try the cutting balloon and so, we won't even entertain that possibility with this kind of things, because regular balloon, even I can tell you, 1.5 balloon would have been trouble also. The non-obstructive patent stent, yeah.
Yeah, no, yeah, but what is the important is that movement. I think people have seen
1.25 bar.
how you move the corsair. With the guide in the left main, you just have to be very, very careful, cautious when you are doing this movement.
So now question here, that's a practical question, that do you use a laser or you use the rotablation? I would say the laser has a chance in this case that may not go about 20%, our experience. Now, the rotablation, the advantage of rotablation will 100% go, or I would say 99% will go, but have a little bit chance that may cause more dissection and of course
Can
perforation.
you give me some dye? Why this is not going way further down?
Want to see dye now?
Slipped back. You had it in a better position before.
No.
I think once here we go.
There may be in a smaller branch there.
Right.
Okay,
Good.
now
That's
we are
good.
good.
Yeah.
Now we are in excellent position.
You hold it.
Yeah,
Hold it.
because you need, yes.
Are we ready, guys?
You need a
All right, our
good
team is
wire
ready.
purchase, yeah.
Our fellows, actually, of the 9 fellows, I would say what, 5 or 6 of them already have done multiple rotablation and orbital atherectomy independently. Of course, everybody is expert in the IVL.
In the first 1.5 months.
Yeah, first and 1.5 months.
No wonder you are the number 4th center. I think fellowship training has got so much to do with it. It's
And the biggest, highest program, and now we'll be part of, soon we'll be taking part of the national match, which is they're making it mandatory. So it's a lot of plus and minus. Okay, guys, get a balloon ready, 2.5, right? 2.5, 15, 12 or 15 balloon. Yeah.
Frank, we have a run through already?
Yeah. Make the. Okay. Okay. Is this ready yet?
Yep, warmed up.
Warmed up.
Yeah.
5 minutes. Wow.
I told you 5
Improving,
minutes.
okay.
The highest laser user.
I had to use a little more laser to understand the timing of getting ready. Good. Okay, 5 minutes. Okay. We are ready to check the speed. Usual.
0.9.
Good. Fine.
Which
Yep.
one?
0.9. Yeah.
Yeah,
Go.
yeah. Oh, you mean the laser?
Yep.
Yeah, okay. Now, right now we are going with rota.
Yeah. So don't stop it yet. In case rota has trouble, we will go to the laser. 1 second. 1 second.
This is a 1 to 5 burr now.
1 to
Yes,
5 bar. Yeah.
yes. Now, can I take a cine to see how the wire is?
You want to take a picture or no? Okay.
Yeah, but then inject. First dry.
Dry. Yeah.
Go now.
Don't even see.
You see it.
Yeah. No, but very clear.
Are you able to appreciate the wire bias already?
You want to go to more magnification if you want.
Yeah. Now we have.
Fluoro, just go again. We go more magnification.
Okay.
And
then,
close them. Yeah. And then we'll do a cine. One more cine. Yep.
Okay.
Go. Go. Guide a little more in. Yeah.
You can
Yeah.
see it.
Cannot see. Yeah.
There. It's
Yeah,
on the
it is
superior surface.
surface. But just to say, what will happen is it's going to create a gutter. Don't be alarmed that you'll see like artery messed up. Little tornado in there. But that's expected. Let's
But
go.
have a balloon ready.
Yep, balloon is ready. Always balloon should be ready on the table. Your wire should be ready on the table. Let's go.
Okay, ready.
And this is the kind of case where we usually may go with the exchange, revive, get ready our Corsair again. You might exchange with it. Usually, otherwise, we go side by side.
Okay.
Yeah. Make sure your Corsair is ready.
Can you go magnified?
Okay, guys, go one more magnification. I'm pulling the wire a little more. One second.
Don't
Good. That's
pull
it.
anymore.
Okay,
Yes.
good. Yep. Same over 3 points. And on diagonal light tap, good. None. Now ready to rock and roll.
It's quite an angulation.
Yeah. Well, that exactly is the point. We wanted to show that how these devices have come across.
No, I think we should not. That's it.
Huh? Why?
It's hitting the roof of the normal vessel. Proximal circ.
You want to go to 130 speed, very low?
Okay.
Yeah, we can do it manually. You are going to go to 130. So the less injury and more flexibility. A lot of people try to do this with a low speed. What do you want? Okay. When you start, we're going to go to low speed.
Some die.
You're still far away, yeah. Good, 1 second. We're going 130. Good. We are at 120.
Oh, okay.
You want to
See what
stop
I'm
this?
saying?
Huh?
No.
Sine, and when you do this, sine, and we come out.
Yeah.
And get the laser ready.
Nice decision.
See that?
Yeah.
Hitting the roof.
So basically, it is not making the turn.
Yeah.
You see that?
So if I advance further, it will just perforate the vessel right now. Agree?
I think let's try once more. One more and then we'll come out. Yeah, now we just say the pull the guide. Yeah, that's it.
Yeah, but the wire has to go further.
The wire is,
Wire is coming
yeah,
out.
Okay, wire can go. Go.
Oh,
No, okay, no, wire is stuck. Yep. So you saw that it did make a little curve, turn with a low speed.
but that's only by pulling the guide backwards.
Yep.
Made it little coaxial. Now, if the wire does not go further, I don't think I have enough wire.
No, that's okay too. Remember, I say partial ablation. You do a half, 1/3. Sometimes that's good
Can
enough.
we advance the wire?
No, wire is stuck right now. Let's see when you do. Maybe I'll try again. No, that's what I'm saying.
Don't.
No. That's okay.
Done?
Yep. Good.
Okay, let's
You're
go.
coming out.
So we probably did 70%
Yeah.
of the lesion. Okay, go.
Corsair again. Keep this straight. Keep looking at the top. There. Good. Get action length run through.
Extend, run through.
Action length. We'll do a laser on that if needed.
No.
So
Now
two things
balloon-
we are going to do. First, we are going to go with the Corsair again because the balloon will not
Take a
go on
picture.
this wire. Yeah. Okay, 1 second. Yeah.
So hemodynamics are good.
So far, so good.
Go,
They're
go,
showing
go.
the hemodynamics.
Okay, good.
Yeah. Good. So this is what I say, that in complex cases, don't persist. Don't wait to go exit the burr, because that may create more trouble. So it's okay to do a partial ablation and try. And I can tell you, every time I tried that, partial ablation always have worked. And we have shown 2 times in our live webcast here. And I done when the no, we did live web in the one, that LED recently. Good. Who wants to connect? One of you hold the laser. No, give us the laser. They'll hold it. One of you guys go other side. Go. And keep it underneath the wet. Yeah. Keep it under. Now, why the Corsair may not go, because it's a rota wire which is 0.009, but that's okay. You go a little more and then we are ready. Make the curve or no? A little bit more. Slightly.
Celine,
Yeah,
could
that's-
you?
I was
put
just
in,
thinking that should be a balloon just on the rotawire.
Yeah, that's
Oh,
what I
balloon
was
rota
thinking.
wire. No, no, no. Believe me, your Corsair is not going. No, no. Please,
No, that Corsair, believe your balloons are better than Corsair.
you want to try?
Yes. That I was going to.
All
do.
right.
That's number one, and the other one I wanted to do side by side
Yeah,
because we have a little channel there.
Yeah. But remember, wire alone, side by side, will not go because that angle still exists. The balloon try is okay, but I don't think the wire side by side is going to work, because you still need then same
good.
catheter. Good. Very good. Okay.
Don't insult.
Yep.
They.
I didn't insult. I said it will go. I didn't say I gave it to you to that it will go. There's no question there. Now, only issue remain balloon versus laser. So we are laser ready, but I will try to see if the balloon goes, then good.
What balloon we have?
We have 2.5 balloon. Compliant or non-compliant?
Compliant.
No, give a compliant in this case. Yeah. Yep, 12 is good. Good.
Yeah, advanced wire.
Going out to the spleen.
Liver now.
Now, is Isha was there today, or
Yeah,
somebody
yeah,
seeing my
she's
cases?
there. Yeah.
Or God is doing it.
AI.
Because the guy is not there today, I'm Uda Muda Puda. All right. Let's say, okay, how things are. What everybody's prediction? We are okay other side?
Balloon will go.
I think the balloon will go.
What is that?
Yeah, balloon will go.
All right.
In my mind, I had a 2-0, but hopefully.
This is what?
2.5.
2.5.
Right?
Yeah.
Okay.
Came
yeah,
approved. Bye-bye. Bye-bye. Good.
Out. Yeah, bring it closer to me.
Okay. You want to use the laser just for the sake of it or no?
No. No, we got to show them that we did partial rota, which
Yeah.
is okay, and partial rota will take care
Yeah.
of the lesion.
Partial rota, that's it.
I would have wanted Godzilla, but nobody wants to.
Yeah. That's it.
Flying, apply brakes.
Well, it only tells
Right.
me that the rotablator did more than what we are giving it credit.
Yeah. No, clearly. So as I said, to teaching point, another one, partial
proximal.
atherectomy, a partial atherectomy concept. Don't worry, angulated, long lesion, you have done quite a bit. Don't worry that you have not done the full circle. We have to pull back a little more, no?
Yes.
That you have, because purpose there is, you have cut the interelastic lamina, and now your balloon will do the job.
So you want what, 3-0? I think
Yeah.
we can do
No,
a stent directly.
No, not directly. Huh? You want direct?
Yeah.
Okay.
It's done. Done.
Okay, Promus. 3 of 16 Promus. Where was Promus last time? Take a picture. Yeah.
No, 3.5, no.
Or 3.5?
Yes, yes.
Okay. Or
Yes.
12?
Yeah, 16.
So you have to be after the 16?
Yes, yes, yes.
Okay,
yes.
16, fine. Okay.
Looking excellent already.
Yeah.
Yes.
So once it is done, they will do a IVAS modification and so once the stent is, and then I'm going to go our discussion.
No, IVAS is not opened.
No, to open the IVAS ready. No, it was open.
Open.
IVAS is ready here.
Any questions? Sir? No.
Like a lot of the trials will be presented in the European Society. Biggest thing we are waiting for the iLumen 4, which will be presented in European Society, I think on 28th or so of this month. That's comparing OCT guided versus angiography guided PCI and complex lesions. Ziad Ali will be presenting that, so that everybody have, keeping eye on that trial. So this is now 3.516. I think we need to open with the high pressure balloon first.
Okay, 3.5.
Your wire is in very small branch.
No.
Yeah. Yeah.
Okay.
Yeah, let's get a 3.5 all that. No, I think we have to just do a little more kick. So I knew that because we did compliant balloon and these angulated calcific lesions we can
No,
never
maybe we did
underestimate.
not.
Yeah. No, but we need a little high pressure balloon. That's it.
Already we are 9 o'clock.
But you saw that another modification we did that do atherectomy at the low pressure, the low speed, which will be less traumatic, and it kind of a more of a dynaglide between dynaglide and your regular speed, that it will go slowly, and it did make the difference.
I think pulling the guide and making it more coaxial.
Yeah. Okay, we definitely can remove the laser now. We don't need it. Yeah, yeah. 16.
Thank you.
Good. Yeah, let's go
So,
up here.
yeah, here there's a little trouble. Okay, good.
Now we are going to go with the same 3.5 or 16 Promus. Keep this, we may have to need to post dilate. Actually, we also created an additional fellowship we call hemodynamic fellowship. And Manish has done structural complex intervention, and he's our first hemodynamic fellow. What is the name of the fellowship? It's some funny name.
Complex.
No, what is the name? Yeah, Advanced Hemodynamic and Mechanical Circulatory Support Fellowship. This looks so impressive. Looks so impressive.
I think this will be invaluable, absolutely
Yeah.
invaluable.
Synergy will go in nanosecond.
No, I think there's a nodule. That's
I
not
know,
allowing
but
it
you
to
have
go.
done the good balloon.
It's the same even with the rota in the
Get the
beginning.
synergy and guideliner, both things should be there. So I think this is a good test for synergy. 3.516 synergy. Otherwise, we have the guideliner anyway. So guideliner, we have to bring it down, which will be simple.
Very simple. Your side by side fielder wire. This will go on the
Right.
fielder.
Just leave it there. So just leave it there.
No, cannot. This has to go on the fielder.
Okay.
Get me the fielder wire. Or do I use a whisper that's here?
Whichever way.
Is there a
We have
fielder
both.
there?
Fielder, whisper, all the wires are there. Good. Keep this one. Yeah.
No, don't open yet.
Don't open that one yet.
You want to try something else? What is that? This is not,
No,
this
no,
is
no,
fighter.
no,
That's
yeah.
fighter. Okay, no? Then
You
I
have the
use
wire
this.
there.
This may be, yeah, fielder? This green is a fielder.
No, we have
no,
it.
no,
we
no,
have.
we have. This is whisper maybe. Yeah, whisper. Okay, we have whisper.
So here you can do few things. One, if you want to go, you have your Corsair. Of course, the first thing is, to me, we used to use all these stiff wires and there's no need. You can put a balloon and put your guide liner or Godzilla further and then your stent will go. That's one. Secondly, you want to go to the stiffer wire, which is okay. Grand Slam and other stiffer wires you can use, change it on your Corsair. Third, which I'm going to do parallel side by side. Now, since we have opened the lesion, and vessel has become a little straight, it has a good chance to go. I know initially it was tough to advance, largely just because of angulation. Good. And now we put a Promus on this whisper wire.
Whisper, the body is not as strong as fielder,
No.
so I don't know.
But
how
you have
to
two of
behave.
them. But you have two
Let's see.
wires. Yeah. But if this does not go, then we'll definitely want to try synergy. Hailed as a very deliverable stent. And definitely, between
Maybe in fact O0.
Orsiro, yes. There's no question about that. Orsiro, Onyx, these are all in the same category. But this should go now because you have double wire. Things have been straightened out. Now here, if you want, you can do a cutting balloon. Try the synergy. Or you want to get a cutting balloon, 3.5?
Synergy won't do anything.
Okay.
Don't even try.
No, try synergy. Yeah, good. Yeah, but let's say cutting balloon.
It's wasting. We already.
No, but that's okay. Yeah, synergy. Yeah. Okay, good. Keep it there. Synergy will try on our run-through wire. So this is actually we're testing. We'll return this to Boston Scientific if one goes versus not other. Now tell us if this does not go, what is your strategy? Anu, cutting balloon, 3-0,
Yes.
3-0. Get
Not
ready.
3
Huh?
to 5.
Okay, 3 to 5. Go. This is the same 3.516. Don't open the cutting balloon yet. As soon as it
Still
does not
think
go,
it should
then
have
we.
gone on fielder.
No. This one.
Okay,
Good.
let's see.
What are you trying now, Samin?
Synergy.
Synergy, okay.
Nothing going. Good. No, good.
Oh,
Went
good,
in.
good,
Went
good,
in.
good.
Went in. Good. Yeah.
It's nothing to do with synergy. It's
Synergy.
the way you
Synergy,
manipulate.
synergy.
We did not try
Predicted.
Promus. We did not try Promus
Why?
on run through.
Originally was promotion
Yeah,
run
but
through.
that time the second wire was not
Yeah,
around.
okay, good. Chalo.
No.
Let's go.
Don't
Take this wire out.
about
Yeah. Yeah.
It's
This prediction.
no, it's nothing prediction. You have to do the right
Good.
things. Yeah.
Ready? Going up. No, but I mean clearly there is we know advantage of synergy, flexibility,
No,
16 atmosphere.
no justice was done to Promus. You should have tried it again on the run through. It did not go. Then you can say that.
Okay, let's pull back. Let's see this because then I start my things quickly. And you need to optimize. Proximal lesion still had to be balloon with a short balloon. Whoa,
Okay, good.
whoa, waha.
Think you may be done.
Yeah, you want to do IVAS? No, IVAS will show. Yep,
Plaque shifting into the ramus, but
very little, that's small, yeah. Okay, let's go to slide while they are going to ready with the IVAS. And so let's go to our slide presentation now. Good. So let's quickly, because we got beyond the time, and I'm so sorry. After a long time, I was a little late to start. I always before timing. After a long time, I was a little late today. And sorry to our audience, keeping them
Started with
waiting.
Central Time today.
And Europe PCR trials, which I'm going to finishing now. And this, after next month, we'll start our European Society ESC trials, which will be many of them. Then we go to the AHA. So trial, field, and the TCT. And all those will continue. So basically, these are the 4 trials I'm going to speak. And more importantly, I'll present the glimpse of our 2023 recent guidelines, ACC, AHA, and so for the management of patients with chronic coronary disease, which they call CCD now. Stable ischemic disease has been changed to chronic coronary disease by America, and it's called chronic coronary syndrome by European guidelines. So these are the basically, so let's go to our first broad after. A randomized clinical trial is the trial of sirolimus eluting bioadapter scaffold, same. Absorbable versus Rotational eluting stent. Our Onyx, basically it's a sirolimus which will degrade with a cobalt chromium thin stents and basically unlock. And idea is that neointimal formation, Dynamax bioadapter versus Resolute Onyx DES, and showed good success rate, procedural lesion success, device success, and overall endpoint at 1 year that non-inferiority, yes, but not a superior. Oh, no difference in stent thrombosis or target MI as shown here. Now, what it show is that basically the pulsatility, that clearly the vessel which got this is the Resolute Onyx, and then if they got basically the scaffold sirolimus, the pulsatility is much better at follow-up at 12 months. So this is one. Second point is the return of compliance, again better with the Dynamax compared to Resolute Onyx, and the blood flow is better. And more importantly, that while acute gain was equal in both, but at follow-up, there is a lower late loss. As you can see there, partial diameter stenosis was lower late loss in the scaffold group compared to Resolute group. And also the stent coverage, very good, both no malapose struts and neointimal formation is lower compared to the DES. So this basically puts it together. And also they saw that behind the stent struts device, a non-calcific lesion actually is negative. You have positive remodeling, and in the lipid containing lesion also, so there is a make a sense that all those patients should be on lipid lowering therapy. Second was the drug coated balloon, now using everolimus. Remember, we showed the data of the paclitaxel before. We have shown the data of the sirolimus. We are part of the trial. Solution DES, we are the highest enroller of 32 cases. We are allowed to do only 35 in a 150 patient trial, and we're doing quite well. And this is a CBT of ISR trial, basically using the everolimus for this purpose. It's a Chenau vascular technology, that's a CVT, they're proprietary, nanoparticle release, a small number of patients, but overall showed these were, same regular way you put those together, and 92% freedom from TLF with 1.2% mortality and 6% TLR. So very good overall historical control. So, and also late lumen loss of 0.4, which is much better than what we expect otherwise. So clearly the longer trials longer data need to be followed, but large randomized trial has started, Everlast, in patients with ISR using everolimus eluting stent for these cases for ISR. Then the Euroshock trial, that do you use ECMO in cardiogenic shock versus standard of care, and basically we know that ECMO is useful, but there need to be a positive trial. Group 1 standard therapy, Group 2 standard therapy versus ECMO. A small number of patients, but that's the only one you can have, about 35 patients. Overall, you can see there's no difference in 30-day and 1-year mortality between two groups. Data shown here, 72% in the standard group, and ECMO is 50. But because a small number did not make any difference in terms of statistical significance. But lower recurrent MI, and more importantly, higher bleeding rate. That we knew, vascular complication and bleeding. There was no difference in AKI, numerically lower. So therefore, it's a, I would say that you need more cases to make a statement of the using ECMO in these cases. Then the same question, provisional stenting in bifurcation lesion, benefit of side branch intervention, KISS study, that do you do, because we know the side branch intervention, make a side branch a little better, maybe lower periprocedural injury, relief of angina, compared to no side branch intervention, that you don't distort the stent technology, no need for second stent. So this was looked into this randomized trial using Resolute Onyx, no side branch intervention or side branch intervention, they left the balloon, then did the kissing balloon, then did the pot. And basically showed primary endpoint was the periprocedural infarction or injury by the arc definition and MI. So these were the cases. As you can see, the pot and all those kissing was done in very small percentage in the no side branch intervention group, but ballooning and side branch quite good in the control group. Control group basically means where you use the side branch intervention. No side branch intervention was the active group, control was the no side branch, but overall procedural endpoint, no difference as protocol 4 to 5, technical success. But what happened is in the control group means when you do intervention of the side branch, you put more procedure time, more fluoro time, more radiation, more contrast volume as shown here. And overall outcome, no difference, and most important was myocardial infarction. It was 3.7 in the no side branch and control group 5.1, numerically higher. No difference in stent thrombosis. So basically the trial basically was negative, of which is this is the fifth one in this series showing no difference of the no importance or no need for a routine kissing balloon dilatation unless there is a need for it. That is, there is a decreased blood flow, chest pain, or side branch pinch to 90%. What I'm going to show data about basically this important document just released last week, guideline for management of patients with chronic coronary disease, CCD, and as you can see, very extensive. They had their aim, methods, structure, took a multiple opinion. Only one thing which has been criticized later, there are very few little surgical opinion. The Surgical Society of Thoracic Surgery, surgeons are boycotting. So there was some, news was going on that they don't agree with the finding of this guideline because they were not involved that much. But the surgeons are not happy with these guidelines, but whatever they are. So let's talk about what changed in those 10 important changes. First was emphasis on the team-based patient-centered approach. So every case, you don't decide yourself, you have to have a team approach. Second, non-pharmacological therapies, healthy dietary habits and exercise are recommended for all patients with CCD. Then patients with CCD who are free from contraindications are encouraged to participate in habitual physical activity and exercises, rehabilitation, all those are included. Then use of glucose transport 2 inhibitors and glucagon-like peptides 1 receptor agonists are commonly given patients with a CCD even without diabetes. Then new recommendation for beta blocker, not routinely recommended, particularly patients who have prior MI or left ventricular dysfunction, or those cases are good. Otherwise, the calcium channel blocker also has come as a class 1 indication. Then statin remains the first line therapy. Even if you're using a PCSK9 and others, statin has to be given to all those patients. Then shorter duration of dual antiplatelet therapy are safe, effective in many circumstances. Cut it down rather than prolong. Then use a non-prescription or dietary supplement including oil, fish oil, omega-3 is not recommended because it has not shown any benefit, although we routinely prescribe. Routine periodic anatomic or ischemic testing without a change in clinical or functional status is not recommended for risk stratification or to guide therapeutic decision making patient CCD, despite even in patient with a post PCI. And lastly, about the e-cigarette that we don't know, but smoking cessation should be there, and e-cigarette are not beneficial anyway. So with that note, there are a lot of data. I'm just going to go through it, which puts it together. And they call it a guideline-directed medical therapy. Until now, was reserved only patient for heart failure, but now has come for the CCD also. And combination of pharmacological treatment and other the dietary treatment and procedural treatment makes it a guideline-directed management and therapy. They also added that anything you do has to have a cost value. high value, intermediate value, low value with the 50 to 150 and more than 150,000 per quality of life gained. And uncertain value and not assessed, that have become part of the guidelines also. And basically they say that these patients, what do you define as a chronic coronary disease? Is basically our patients with not acute coronary syndrome. Acute coronary syndrome has been stabilized. Now they come later on, they are the chronic coronary syndrome with or without LV dysfunction and with or without ischemia. So they, whatever our class 1, 2, 3 used to be, they have made little more modification, particularly in class 3, which moderate, no benefit or harm clearly. And then on class A, B, C, they have added the randomized and non-randomized and limited data and added about the cost of the treatment. Now this actually, I really loved it. I'm showing this slide to say that what is the incidence of coronary artery disease in America. So it basically is 7.2%. Of course, it will change with the age group and other race and so, but overall 7.2% Americans have a coronary artery disease, more than 20 years of age, and MI occurs in 3.1%. Very interesting. And then of course 11 million, means half of the CAD patients have angina pectoris. So with the different age group, clearly incidence of the CAD continue to increase. These are the basically global representation. And then question comes is that, as I mentioned, that it's a shared decision making. It's not one, it's patient and of course the clinical care team, but everyone. For the nutrition, expert, patient education, the exercise, socioeconomic factor, all those support are needed to manage these patients. And diagnostic, clearly we would, they decided that patients who have, question always comes, that which patient with you suspecting coronary artery disease that we should get the testing. So they basically showed that if a patient with the chest pain comes in, then you have change in symptoms or functional capacity, then you do a stress test. Otherwise, you manage those patients medically. The risk stratification point of view, that all the patients with the non-invasive, invasive testing, you have to identify patient in the low, intermediate, or high risk. That's the way it has been in the past. And of course, the question remains that patients, the treatment, that you optimize treatment to reduce MACE in these patients. So these are the various high-risk factors they have done. I will just go through quickly, but this is to have it. As I mentioned, that routine stress testing, it's been avoiding. Now then, basically all about the diet. There's quite a bit in terms of various approaches for these patients with the patient education, decision making, and there's a lot, as I said, the true revascularization has only like 3 pages. Of the 100 pages, all they're focusing on the global management of patients, and of course with a special emphasis for women, that what especially we need to do extra for their care. Nutrition, including supplement, and what to eat, what not to eat, particularly avoid trans fat, baked goods, fried foods with hydrogenated oil, shortening, French fries, bye-bye. And mental health, a lot of emphasis on mental health, tobacco products, smoking cessation, as I mentioned, alcohol, substance abuse, the guidelines for everyone. And then patients with that how to manage and what to do for these patients, sexual health activity, that the patient, what can they do, cannot do, lipid management, nice graph for based on the risk factors that of high dose intensity for these patients. And then blood pressure management, again, very strict blood pressure management, aggressive, multiple drugs, and then SGLT2 and GLP-1 receptor agonist, even patient without diabetes, because they also have reduced weight, and they talk about this weight management for these CCD patients. Cardiac rehabilitation has really, they have put it up with increased physical activity. People say, well, how much activity you should do? It's 150 minutes per week of moderate intensity aerobic, or 75 minutes per week of high intensity aerobic is your class 1. And then, of course, less than that, you do 2 days, is become class 2 and so. Antiplatelet therapy, already have said that they're going to reduce the total duration of anticoagulation. Our antiplatelet therapy with anticoagulation, with a NOAC and DOACs, you give antiplatelet therapy for short period of time, 1 month, and then go with a single antiplatelet therapy. Then the medical, clearly as I mentioned, that beta blocker, other renin-angiotensin, aldosterone inhibitor, colchicine has come to the line now to be indication because of the benefit. And patients who are refractory to medical therapy, then there basically is that what you do for those patients. So those patients should undergo cardiac catheterization. They have heard about the ECP and chelation. Both are useful. And revascularization. This is a goal for us, that patients who have lifestyle limiting symptoms, significant CAD amenable to revascularization is recommended to improve symptoms. So basically that where it is. Cost value is quite good. And here really well down to that if your EF is less than 35, then only they are suggesting more cabbage. Otherwise, PCI is equal. So that's where the surgeons are not liking this statement. Even you have complex disease, that the CAD we know like PCI can be done in many of them. And what they have done is they have downgraded the syntax score. So key is your class 1 patient with required revascularization was significant left main associated with high complexity CAD. Cabbage is recommended in preference to PCI to improve survival, but PCI can be done. And the syntax score incorporation has gone down a little lower. And patients who are high risk for surgery, PCI is class 2A indication. And also patients with a chronic coronary disease with diabetes with multivessel disease, left main and 3 vessel appropriate for cabbage. They'll definitely put a cabbage on that. Lot of work on the non-obstructive vasospastic angina, microvascular angina, INOCA, special emphasis of adult disease and of course the obstetric patients. So very extensive document for geriatric patients. They call mind, mobility, medication, multi-complexity and matters most. And the follow-up. This is again emphasizing on the follow-up. See class 1, no benefit of the routine stress testing in recommended to guide therapeutic decision making. So all stress tests are out. And then, of course, I say CTA is very important. Then they say some evidence gap is still lot more need to be done. So let's talk about our overall outcome point of view. Sorry. So the take-home message: sirolimus eluting bioadapter scaffold at 1 year. Yes. Everolimus coated balloon for ISR. Yes. Routine use of ECMO in cardiogenic shock plus minus, little lower mortality 22%, but did not make it, but very high vascular complication. And routine side branch intervention, bifurcation lesion, again thumbs down. And recent guidelines for stable CAD have emphasized on multiple global management of the patient and so. So let's quickly finish 3 cases, questions. Following statement is false regarding the 1-year results of the bioadapter sirolimus scaffold versus DES in randomized trial. Lower TLF in scaffold, similar TLR in scaffold group, higher scaffold thrombosis versus DES, lower late loss in scaffold group, and higher pulsatility in scaffold group. Clearly, there was no higher thrombosis, so this is wrong. Second, question: following statement is false regarding the results of Euroshock trial, comparing ECMO versus standard of care. Similar overall primary endpoint between 2 groups. Numerically lower mortality in ECMO, numerically lower MI rates in ECMO, similar AKI in 2 groups, similar vascular complication between 2 groups. The answer is E is wrong because higher vascular complication in the ECMO group. The third question: KISS study comparing no side branch intervention with routine side branch, which is called control group, result in the following, except higher contrast use. In the control group, higher fluoro time in the control group, similar TLF between 2 groups, lower MI rates in the control group, and similar stent thrombosis between 2 groups. Remember, control was your bifurcation intervention group, and that's a control they call it. And premise was that this will give rise to lower MI, and answer was no. It was MI rates were similar. So this was basically was the wrong answer. With that note, we complete our presentation, and Anu will show the last angio and maybe the IVUS on this particular case.
Just show the IVUS.
Only you could do this half a textbook of cardiology in 20 minutes. Unbelievable. Very comprehensive review. Anu, tell us.
Okay,
Now you can show the IVUS.
This is a native vessel coming to the proximal. So now I show that this is the distal edge, perfect, normal position, and no dissection, well expanded. So now come to the tightest part. This is the tightest part. So you see that like 9 to 12 o'clock, the calcium behind a stent. This is a calcium nodule.
Yeah.
So
Remember we said was calcium nodule. They were not allowing our stent to go. Yes.
Right.
Yeah. But area is 9.2. So
Yes.
and the other part is the healthy. So if it's aggressive balloon, it's going to be the risk of the population. So it's a safe and good result. So if we go to the proximal edge, this is on the plaque, but normal position also.
Yes.
So we didn't come to the all the way to the proximal, so normal position. And
Beautiful.
actually, proximal circ, this is like a snowman shape. So this is you ablated. So that's why every device goes through the lesion. So this is a good plaque modification. Stenting is perfect.
All right, show the last angio also, just to remind our audience the last angiogram. You have the last picture?
Yeah.
Go back to the fluoro, and we end up with this. Yeah,
No.
yeah, not the first one.
No. You'll be now going.
Minus.
Yeah. Okay, this is the final. Uh-oh.
No.
Yep.
And that
Yep.
should be the one. This should be
Yeah.
the one.
And another minus. Beautiful. Look at this.
This
Wow.
is the one we need, this view.
Yeah,
Excellent.
that's the case. All right.
Congratulations. Exceptional skills as mentioned before. Hopefully this would have been numerous tips and tricks. So many support catheters, guide wires, technique, laser, rotablator, just about everything got covered. Samin, Anu, congratulations on an excellent case. We'll end the session here and see you on September the 19th.
So contrast volume.
Oh, sorry.
Go ahead, Anu. Go ahead. You can tell us.
Yeah, contrast volume 120 cc, and total fluoro time was 33 minutes 23 seconds. Air karma of 1.5.
Wow.
We always goal the air karma should be less than 2.
Excellent. Thank you for providing that information. We'll see you next time, September 19th.